access and equity. We have issues that pertain to emergency and referral mechanisms. We have issues with humanitarian crisis. We have issues that speak to vulnerable populations. So if you can remember the blocks plus what I'm saying, you'll be home and dry as far as the health system is concerned. So we want to first invite our first speaker, who's Denga et al. I hope you are there. You will be talking to us on strengthening equitable access to life-saving maternal and newborn health commodities through the supply chain reforms in Kenya, a national health system approach. So over to you. Are we there? Are we online? Are we online?
Yes.
Excellent.
Good afternoon, everyone.
Afternoon. Please go ahead.
Yeah.
We're giving you 5 minutes.
Thank
I
you.
know you've been waiting for us, but thank you for your patience. Go ahead.
Thank you. My name is Ann Kipsuto. I work for Viwala Community Alliance, and I'll be making this presentation on behalf of Ms. Alinda Denga. And thank you very much for the opportunity to present this work on strengthening equitable access to life-saving maternal and newborn health commodities through a national supply chain reforms in Kenya. This work reflects Kenya's commitment to reducing preventable maternal and newborn deaths, strengthening the health systems that ensure life-saving commodities are consistently available where and when they are needed. As we all know, postpartum hemorrhage remains the leading cause of maternal mortality worldwide and also in Kenya. And as much as WHO recommends interventions such as using instable uterotonics, tranexamic acid, uterine balloon tamponade, and pneumatic anti-shock garment alongside calibrated obstetric reps, we've had still challenges in identifying effective interventions, especially health systems that can consistently deliver these interventions. And therefore, recognizing these challenges, the Ministry of Health and its national partners sought to understand why these life-saving commodities remain difficult to access despite clear clinical guidelines. So the review that we did in Kenya revealed that barriers extended far beyond procurement. We had weak forecasting systems, inconsistent quantification, fragmented procurement processes, as well as inadequate financing and limited visibility across supply chain, and also weak reporting, which resulted in frequent stockouts and inequitable access. To address these systemic barriers, Kenya, through the Ministry of Health, adopted a comprehensive health systems approach rather than focusing on individual commodities. So the ministry convened a multi-stakeholder technical review involving government departments, procurement agencies like KEMSA, regulatory institutions, and development partners. So together we examined every stage of the supply chain, including commodity specifications, forecasting methodologies, quantification, procurement pathways, market availability, pricing strategies, regulatory requirements, and national catalog inclusion processes. From this, the stakeholders identified implementation bottlenecks and developed consensus recommendations to strengthen the supply chain at the national level. So what happened? From this work, we had national health system reforms. that shifted from donor-led procurement to government-led procurement. This revenue generated several important outcomes that collectively strengthened the implementation readiness for health commodities. And subsequently, we are foreseeing reduced stockouts and also seeing county taking lead in terms of procurement. So what shifts did we see in addition to this? From this assessment and from this technical review, evidence-based national quantification was completed to guide procurement planning for the year 2025 to 2027 period. Pricing recommendations, market shaping strategies were also developed to improve affordability and promote more efficient procurement. But importantly, this review also recommended the inclusion of pneumatic anti-shock garment and uterine balloon component in the Kenya Medical Supplies Authority catalog, alongside the incorporation of calibrated traps and selected diagnostic technologies like the obstetric point of care ultrasound. To mention is that the recommendation to reclassify NASG as a medical device will be key in providing an opportunity to reduce procurement costs and also improve long-term availability. So from what we have learned from this work is that rather than evaluating the clinical effectiveness of individual commodities, the review that the stakeholders did addressed barriers to adoption, implementation, readiness, feasibility, and sustainability. And in doing so, it established necessary interventions to be delivered consistently across the health systems. And this had various implications, like the policy in Kenya, for instance. The national government has taken a critical role in coordinating all the work of F&Q regulations, financing, and to ensure sustainable access to these commodities. And from this also, we want to see the government, especially the county governments, taking a key role as well as rolling down these reforms at the national level to ensure routine commodity reporting, improve forecasting practices, and integrating these commodities into the annual procurement plan. And as partners, we can also continue investing in long-term health system strengthening rather than parallel procurement mechanisms to ensure that we have our county-owned and also sustainable commodities and health facilities. In conclusion, this really demonstrates that reducing maternal mortalities requires more than introducing new medicines and technologies. It is important to develop systems that addresses systemic barriers to access to procurement, availability of these commodities. And as I close, I want to acknowledge and appreciate the Ministry of Health in Kenya, the various divisions, including RAMPA, Health Products and Technology, and other implementing partners, including CHAI, Health Procurement Africa, Wala Community Alliance, just to mention a few that have led to the development of these national reforms that is really key in addressing access barriers to key health commodities, especially for management.
Now, can you put this on? Okay. Before you go offline, please, can we get a question for her? I'll ask one. We have something we call HPT, Health Product and Technologies, and I've seen this in a few counties. I don't know how many of us know about HPT, Health Product and Technologies. It's in a few counties and really is to complement the work of trying to procure commodities and also the technologies to be addressing critical emergencies like PPH. I don't know whether that team has a linkage into what you're doing in the national reform agenda or whether counties are working on their own. Maybe you can give us a word on that.
Thank you, Prof. Kihara, for that question. And to respond, yes, at the national level, we have closely worked with the Division of Products and Technology. And for instance, Wala Community Alliance supports 5 counties in Kenya: Migori, Homa Bay, Baringo, Nyamira, as well as Siaya. And through support of Wala and other partners within those counties and the county governments, we have been able to strengthen the governance structures to ensure availability of commodities. And key to note is that all these counties currently have functional county and sub-county health products and technology units. And key to note is that through our collaboration, we've been able to support these 5 counties to develop county on forecasting and quantification reports that will be key to have these counties quantify commodities as well as plan them, even in the annual work plans that currently counties will be implementing for the year 2026 to 2027. Thank you.
Thank you very much. You can stay on if you're able to continue listening in, because I know you're interested in the health system. But back to the ground. Evelyn, where are you? Evelyn, please come. You're the next presenter. In the meantime, can we clap for her? A kilo clap. Hapana. Kilo clap inaenda factorial. 3, 2, 1. Sawa. So we go 1, 2, 3. 1, 2, 1. Thank you. Evelyn.
Good afternoon. My name is Evelyn Mwasia. I'm from Kajiado County. I'm representing an organization by the name Ewangan. And currently we're implementing an Accelerate program that is supported by the Denmark Embassy and hosted by Population Service Kenya. So my presentation today will focus on ending preventable maternal deaths among women with disability in Kajiado County through strengthening inclusive maternal health systems. I'll begin by explaining the barriers that we have in Kajiado County. Most women with hearing, speech, and intellectual impairment have communication barriers when it comes to accessing maternal health care at the facility, because most of the facilities there, we don't have interpreters. Another challenge we experience, the women with disability experience, is competence of healthcare workers. Most of the curriculum lack specialized training on inclusive reproductive health, hence cutting out the women with disability on matters maternal health. Another challenge, definitely, we have the harmful cultural practices in Kajiado County. We have challenges such as the belief that giving birth is a natural process and not a medical process. And then lastly, we also have timely access to emergency obstetric care as a result of the terrains the challenge with terrains in Kajiado County. Our strategic objectives, number 1 is systematic integration, and the other one is reducing obstetric delays. And our target population are the women with disability, the marginalized girls, and the maternal providers. Our intervention methodologies, number 1 is provider capacity development, ensuring that the curriculum for the health providers have inclusive reproductive health. And the other one is grassroots peer support. And as an organization, we ensure that there is peer support in the grassroots by having community engagement sessions and sensitizing the community members, especially the women with disability and the vulnerable girls, on their sexual reproductive rights and how the importance of accessing maternal health care at the facilities. Another intervention is emergency referral coordination, ensuring there is timely access of emergency obstetric care. And then we also have community dialogues, and then as an organization we use art, that is skits and dances to, because Kajiado County, most of the community members there are illiterate. So we incorporate skits and dances so that we're able to pass information, and this the skits and the dances are themed depending on the challenges that are there in the community. And lastly, we also ensure inclusion of women with disability in maternal and SRHR programs through advocacy. So in conclusion, I'd like to say, safe motherhood must leave no woman behind. And this can only be achieved through deliberate investment in equitable and disability inclusive maternal health care. Thank you.
Please keep your questions. I think that's a very interesting area. We really appreciate you, Evelyn. I know that's an area where we don't even have a curriculum on SRHR that speaks specifically with the sign language and the Braille. But I'll have questions for you regarding that because I've been trying to penetrate that area. My next speaker is Domorita Hope. Please come forward. She will be speaking to us on community-based SRHR advocacy as a strategy for improving maternal health awareness and referral uptake in West Pokot County, Kenya. Introduce yourself, please. Introduce yourself in the meantime.
My name is Hope Domorita from West Pokot County. I know most of you have hear that in news, only about banditry. Yeah. We're working in bridging the gap of community-based approaches to improving maternal health among adolescents in West Pokot County. I'm a youth advocate, student journalist in West Pokot, and through my organization, I work with Now and Beyond. We work with Denmark, Kenya, and Accelerate program hosted by PS Kenya. And as you know, Accelerate programs under they work under this theme 3 zeros. Zero unmet needs for contraceptive, zero prevention of harmful cultural practices and FGM, and zero preventive maternal deaths. And today I would like to share our experiences and lessons from working with communities in West Pokot County. West Pokot County continues to face several maternal health challenges, especially among adolescents, girls, and many women. Many girls become pregnant and at young age, and because they have limited access to accurate reproductive health information and services. In West Pokot, there are a lot of cultural practices, poverty, school dropout, stigma. This makes difficult young mothers to seek health care and early. Also, banditry affects this. These challenges increase the risk of complications during pregnancy and childbirth. Teenage pregnancy remains one of the most biggest concerns in our community. Many young girls leave schools after becoming pregnant, while others are unable to access antenatal care due to financial and social barriers. Without proper information and support, many adolescent girls make decisions that affect both their health and future opportunities. Our community response is to address these challenges. I have worked closely with schools, health workers, Declares Kenya, Population Service Kenya, community leaders, young people. I've conducted awareness sessions on menstrual hygiene, reproductive health, family planning, and gender-based violence. Also encourage young people to seek health services and speak openly about the issues affecting their well-being. Some of the activities we have conducted are school health education centers. This is where we go to schools, create awareness about maternal health, menstrual health, and we have also celebrated Menstrual Hygiene Day. In West Pokot, such events brings people close. When we go to these events, it attracts a lot of people because it's very scarcely populated interior. We've also done community dialogues with parents and leaders, distributed menstrual hygiene information, partnered with PS Kenya. We do radio talk shows. Even currently, as I'm speaking, our organization are in local radio stations working with Population Service Kenya. Advocacy for the 3 Zeros initiative, community dialogues with parents and leaders. Our impact is, although changing behavior takes time, we observed positive results because many girls became more confident in discussing issues of menstrual health and reproductive health issues. Teachers and parents also have become supportive, while the community discussions around maternal health has become more open than before. The challenges we are facing are cultural beliefs. FGM is still practiced in West Pokot, very highly practiced. This discourages women and girls seeking reproductive health services. Poverty also limits to accessory sanitary products and healthcare. In addition, long-distance health facilities continue to affect many families in rural areas. In West Pokot, there is this place where it's 300 kilometers from the county, the biggest county referral hospital, 300 kilometers. My experience has shown a lasting change is possible because when the community is involved and we believe working together with school, healthcare providers, parents, and local leaders help us to reach more young people and build trust within the community. Our recommendation is to improve maternal health outcomes. We need to increase access to youth-friendly health services, strengthen the community education programs, invest in menstrual health initiative, and support girls to remain in school, building a stronger partnership among organizations and government institutions. Our future plans are, we are going forward to expand our community outreach programs and reach more adolescents with accurate reproductive health information. We also aim to strengthen partnership and promote safe motherhood, mental health, and gender equality. Improving maternal health. In my conclusion, improving maternal health is not the only responsibility for health facilities. Community also have important role to play in supporting young people with knowledge, guidance, and services. When we invest in adolescents' health today, we create a healthier mothers and strong communities in the future. My acknowledgements are to PPH Foundation, PS Kenya, Now and Beyond, where I work with Declares Kenya, North Rift Radio, that's a local radio station in West Pokot, volunteer schools, and all partners who continue to support maternal adolescents. Thank you, and I appreciate for the opportunity.
Ladies and gentlemen, I hope you recognize two things. Communities matter. After all, haven't we all come from communities? Have we? And then there is something, don't go away, you're running. Come. There is a distinct difference here. What is it? Ini Gen Z. They have the energy, harness it. Thank you very much. Great. So I'll move on to the next. Please keep your questions, because they should be coming fast and furious shortly. I want to speak to Kamau. Kamau, are you here? Hello? Where's Kamau? Oh, good. So Kamau et al. Will be speaking to us on adopting peer support model and longitudinal follow-up of pregnant women with maternal anemia. Anderson Medical Center in Trans Nzoia County, Kenya. Please give us a little bit more details who you are, then take the stage. Thank you.
Good afternoon, everyone. My name is Margaret Muihaki Kamau. I work for Ampath Uzima. Ampath is widely known for care and treatment of HIV, and sorry about that. So I'm a nutrition officer supporting nutrition activities in Trans Nzoia County, where we are implementing a health system strengthening project for RAMCA. So I'm going to share a best practice that in collaboration with Anderson Medical Center, which is today represented by Dr. Linda. I'm requesting if you could wave. Yeah, that's Dr. Linda, who has championed and seen the implementation of these best practice. It is adopting the peer support and longitudinal follow-up of pregnant women identified with maternal anemia, something that we have been discussing here since yesterday. And I appreciate Prof. bringing up the issue of nutrition, playing a key role preconception, during pregnancy, and postpartum. So as we can see, I'll not say much about maternal anemia. We are all conversant with that. But I will highlight the efforts the MOH Kenya has brought towards policy in terms of identification, management, and even looking at what image you are seeing there. It's one of the IEC material towards preconception care. And peer support is one of the innovations that brings the experience. Women are able to share their experiences and guided by a healthcare worker who is a reliable source of information, and not just relaying the information, but relaying the information in an effective way. And this Anderson Medical Center decided to use this model to see how to manage, to encourage positive practices. So the objective of this was to improve the nutritional status and health outcomes. So what was the justification for this? Anderson 1, it's a cross-border facility. Trans Nzoia County, being the breadbasket, is equally vast, and we are at the border of Uganda, and we border our West Pokot. Hi, thank you. We experience very significant challenges there. And being the breadbasket, you would think that undernutrition or micronutrient deficiency may not be a part of it, but we appreciate that we have anemia cases, and it is a contributing factor to our maternal outcomes. Again, there are weak mechanisms when it comes to adherence on some of the interventions like iron and folic acid supplementation, and recommended attending the 8 contacts. Women will come to the antenatal clinic late, therefore impacting negatively on their outcomes. And so longitudinal follow-up ensures that women will be accountable to each other and will also have a harmonized return to clinic, and they will be able to access services and information and also address their challenges timely. So this is data from the Kenya Health Information System showing the percentage of anemia among those women presenting with pregnancy in this facility. And as you can see, we sought consent for these women to take their photos, and you can see that there are quite a number. And this is one of the learning forums that they undertake during their routine visits. So the process was having identifying this facility with high anemia mothers, we sensitized the healthcare workers, all of them. They are key players, starting with the lab, the pharmacy, in terms of quantification of even reagents and the commodities that they'll be used. And then there was need to educate the healthcare workers on the management protocols of anemia in pregnancy. And so the identified mothers were grouped into, they were identified, 99 of them. And those who consented to join a group were formed the group, and also those who did not consent, they received the individual interventions. So the mothers in a group were harmonized based on their gestational, and then they would be given a return to clinic date appointments the same. They also formed a group leadership who will be in charge of when they will come back and reminding each other, and also forming the norms and norms of the group meetings. So during the group meetings, they would share their experiences. The healthcare worker would unpack the topic of the day, and then they would also conduct demonstrations on dietary diversity, and the follow-up continued. So these are the findings that initially, when we were starting this, that is in September 2025, the mean HB was at 10.1, with the lowest mother having a HB of 7.5. And during the beginning of the intervention, and these mothers will be given the interventions, that is the iron and folic acid, 120 milligram, and folic acid 400 microgram, and then they will continue with the dietary diversity and focusing on iron-rich foods, and they'll be offered a repeat HB, and as you can see, there was an improvement in hemoglobin levels among the mothers who were in the peer support groups. And additionally, they self-reported to have maneuvered the side effects with anemia and even accessing the iron-rich foods. There is usually a misconception that iron-rich foods are a bit expensive, but we are able to maneuver the dietary diversity providing iron-rich foods. And also, there are deep-rooted myths around how frequent a mother would take, because it is cited that if a pregnant mother eats frequently, they are likely to get a big baby and have a difficult delivery. So maneuvering that is done during the peer support. And lessons learned that the healthcare workers play a key role. They are the front line. And so if they get the right information, they are able to carry the mothers around it and implementing. So the peer support also enhances the quality of care in terms of mothers coming back in time, and since they will be accountable to each other, and also they will share their experiences, encouraging other mothers to adhere to optimal practices. So Anderson Medical Center being a private facility, it has shown that this group A and C is doable and can be replicated elsewhere. And just like in the continuum of care for mother and child health, Group A and C is an innovation that is worth undertaking. There are barriers, like one that comes with financing, especially when it is out-of-pocket pay. This is a facility that is at the cross-border, so we are not only serving the Kenyan community, but also the Ugandans who may not access SHA. I don't know how our Ugandan doctor will help with that, if they could also implement this on their side, so that these mothers can also get these services. And the community, just like the previous presenter has said, has a role to play. The deep-rooted myths, misconceptions, and taboos are barriers into uptake of the recommendations that we have, and especially when it is in low socioeconomic. So as I conclude, peer support model has proved that there is improvement in practices, and as you can see, these are the 10 food groups that we recommend for mothers, but this can only be achieved if the healthcare worker is able to communicate effectively and in scenarios that, in a way that the mothers will relate and uphold their socioeconomic levels. So in recommendation, there is an intervention by the division. It's called Baby Friendly Community Initiative. It's a peer support model in the community, teaching mothers running from antenatal to the second birthday of the child, and that is the BFCI. This peer support in the facility could complement the BFCI and targeting to improve the maternal and newborn health. So I'd like to acknowledge the county government of Trans Nzoia, and also, let me begin with MOH because they're the ones who provide us with these guidelines. I'm sorry I omitted that. But the county government of Trans Nzoia, the NDBES Primary Care Network, the Anderson leadership and also the healthcare workers, and also Ampathuzima and Department of Agriculture. You see a sack there. It's a symbol that we can produce food at various levels, and also that will help us have the dietary diversity. Thank you, and I'm sorry for taking more than 5 minutes.
Give me 2 examples of iron-rich food.
Fresh fruits.
They can't hear.
The
Is it
major-
nyama choma? Can I take nyama choma? Can I take a Guinness? You know, these are the things women will tell us, isn't it? So tell me, when you tell me food diversity, what is that?
So thank you, Prof. It takes us to this food, I'm not sure, yes, that one. The 10 maternal food groups. The major one, the one that we really advocate for is the flesh foods, that is the lean meats, the liver, organ meats, and there's a misconception that most organ meats are do not have nutritional value. I am here to demystify that they are very nutritious, especially in pregnancy, especially liver. And then the legumes, but the issue about legumes, again, it comes with the anti-nutrients. We have to soak before we cook the legumes, and that increases the iron bioavailability, and also the dark green leafy vegetables, which now the cooking practices there interfere with the bioavailability. So that is the part of the package of nutrition.
So how should we cook those?
Wow, if we were to start that, Prof, I'm sure it's better.
No, you know why I'm saying this? I want to challenge the men in the house. Do you really know we need to soak the beans and the peas before we cook? Say no. That's the truth. If I talk to Prof and I tell him a bean sprout is better than a bean, he'll say, I don't know what you're talking about. So we need to challenge ourselves to get to know food diversity and even how to grow it. Thank you very much. So keep your questions coming. Excellent. Now there's a group I left out, Mwanokorie et al. The Nigerian group, sorry for that. Huh? So my Nigerian brothers are speaking on maternal and perinatal outcomes following preeclampsia and eclampsia, diagnosis and referral from a primary healthcare center in northern Nigeria, a prospective observational study. Please introduce yourself, and it's good to see you in Kenya. Please keep coming.
Okay, I think while it's been set up before my timer starts, I think I'll just steal some time.
Yeah.
Okay, so I think I remember the story of someone who, more of a housekeeper who had to travel with his boss impromptu. So they went to a fancy place in Monaco or somewhere, and then while they were serving dishes, they kept tapping him, what would you eat? What would you eat? And he didn't respond. So when he finally responded, he was like, I don't want anything, I'm just happy to be here. And I think that's how I feel. I am happy to be here because I think doing something for the first time, I can tell you from experience, is actually challenging. It takes a lot of grit to push yourself to do it, to make it happen. And gatherings like this for me, they spur innovation. Yesterday I was motivated from the hackathon, and then some of the presentations really stayed with me, and then it gives hope and strength that we are we are together in this fight against preventable maternal deaths. 11. Yes. Okay, so my timer has not started yet. Good for me. Okay, so yesterday there was a presentation from one of our senior colleagues on Iraq, if I'm correct. So there's an analogy he gave using the aviation analogy, which I want to modify. So I've called it out that I want to modify it, so he doesn't say I plagiarized him. So, but I want you to imagine a situation where you have an airplane with 500 women, different emergencies, preeclampsia, PPH, different emergencies, and there's a pilot, the plane is about to crash. And then, in such a situation, what the pilot can see is the mountain and a goat. Do you understand? It's a no-brainer what the next step will be, which should be to attempt to either go back up or land the plane. But in the context of maybe the African context, because some of these challenges we experience in Nigeria is mirrored by Kenya, mirrored by Rwanda, mirrored by the entire African continent. Now, the goals in this instance are everything you need to provide care for a woman. Referrals, the hospital itself, nurses, doctors. Now, choosing to land the plane is quality of care. So I'm trying to say that my topic today, I'll be focusing more on the quality of care gaps seen through the referral journey of women from primary healthcare facilities, which is synonymous to maybe level 2 or 3 facilities in Kenya, up until secondary facilities. My name is Segun Oladipo. I am a medical doctor and epidemiologist. I work closely with NANMA. We are from Solina Center for International Development and Research, headquartered in Nigeria, but our work cuts across different countries in Africa. I won't belabor the problem because we already know that maternal deaths arise from preventable causes, and Africa contributes a lot to it. Nigeria is probably a big brother in this contribution. Yeah, so side by side with PPH, there is preeclampsia. Preeclampsia is literally in a close handshake with PPH. And in my opinion, if PPH is addressed in a silo without addressing preeclampsia or hypertensive disorders side by side, we'll have a situation where we've crashed deaths from PPH and then we have to face preeclampsia and eclampsia head on again. So we did a phase 1 study where we essentially looked at the barriers to care, and then some of those barriers to care led us to answer the question of what happens to the woman in terms of care when they go through this referral pathway. So what should happen ideally? I think this is what should happen everywhere. There might be some modifications, but when a woman presents with preeclampsia, eclampsia, or any hypertensive disorder, and then she presents at that entry point, the PHC, usually a BMONG facility, the diagnosis is made. Usually, the healthcare worker is to stabilize, give seizure prophylaxis, which is magnesium sulfate, and antihypertensive if available, and refer. So stabilize and refer. Now you're referring to the higher facility because that is the last hope of the woman. Now at the facility, care is supposed to be continued rapidly, magnesium sulfate administered, BP control, any emergency care needed. Then the delivery, one of the key factors to the safety of the mother and child is expedited delivery. There should be no delay in delivering the woman, especially when this is a presentation at or near term. So in the end, we have healthy mother and child. But how closely does this align with what is being practiced? Let's look at what we did. So we picked one of the states in Nigeria with one of the highest burden of maternal deaths. It's Kano State. And we now analyzed, we picked LGAs within the states that are high burden as well, picked PHCs that take a lot of deliveries, and then in the end, there were about 20 PHCs. So what we did is that we now focused on the journey of the woman from when they present to the PHC up until referral and when they arrive at the facility. This was mostly prospective and observational. So the major question we wanted to answer is, what's the quality of care at the PHC and referral center, and what outcomes does this lead to? Now, in our results, we saw that at the first point of contact, the care began to fracture. Very obvious and something disheartening to see. Only 29.2% of the women that presented at the PHC and were diagnosed received seizure prophylaxis. Now, only 19.2% out of all the women that presented received any antihypertensive, and only 25.4% received maybe just one of each of these treatments. And then 72.3% of the women completed referral. Most of our discussions today will not be focused on the completion of referral, but the quality of care received at both. Now, 42.3% of eclamptic women, that's 11 of 26, who had already convulsed, were transferred without any seizure medication at all. Some reasons for these gaps include, and some of these reasons, like I said, we identified them in our phase 1 study we did in 2024. Lack of training at those entry points, lack of skill bed attendance, cultural beliefs, financial constraints, healthcare system trust, religious beliefs, influence of traditional medicine, and community-related issues. So definitive care at the referral facility became the only hope for this vulnerable woman. Now let's go to the referral facility. At the referral facility, quality of care continued to lag. So over 85% of the women were at or above 34 weeks of gestational age, and 54% had severe hypertension, that is BP greater than 160/100. So they were in a situation where intervention needed to be rapid. But still, out of this cohort, only 46.8% received further magnesium sulfate, only 74.5% received antihypertensive. And then one other detail we found that was a bit concerning was that most of the deliveries turned out to be vaginal deliveries. And within that time, you can see that many of the women were kept in the facility for a while, median stay of 2 days, mean of 3. There were women that stayed for up to 13 days. And even after staying for up to 13 days, they were discharged for care on outpatient basis. So we had a cesarean section rate of 9.8%, which is quite alarming because from other studies we compared to, the CS rate was above 70%, which makes complete sense. Because if you're trying to expedite delivery for a woman that is vulnerable on her way out, you need to just get the baby out, which is the solution. Now, additional gaps identified at the referral facility included no folders were opened for the admitted patients, delayed or absent clinical response. One of our colleagues today spoke about multiple delays. So delay in or absent clinical response on arrival, no bed space, no MPCDSR conducted for the stillbirths. Now, possible reasons for these gaps include delays in completion of the referral, limited clinical decision-making, inadequate CMONC surgical capacity, and shortages of skilled obstetric care providers. So the problems at both levels led to sad preventable statistics. We had a case fatality rate of 3.8%. So 4 women, out of these 4 among those deaths occurred at the referral facility. So even after the woman arrived, with the hope that arriving was her last hope, we still had women dying there. Now, 24.5% were discharged with complications, including AKI, kidney problems, and a lot of things. Now, 2 women left against advice, 1 later died. 28.5. So one of the most alarming findings from this was that there were many perinatal deaths, over 38 deaths of babies, 26% preterm birth rate, and then there were more convulsions at the referral facility. Now, we now try to be sure that there were no other factors contributing to this. We now did some form of logistic regression and saw that severe hypertension at the PHC presentation was the most significant association between with perinatal death. So if a woman convulses at the PHC level, there's a high chance that she's going to lose the baby if there is no proper care along the pathway. So in conclusion, I will just conclude with a call to action. We can see that the gap is at both levels. So everything we are calling out cuts across all the levels of care. So we are saying that there needs to be strengthened clinical decision-making for preeclampsia through targeted training, decision support tools, and mentorship to provide timely escalation and delivery decisions at both levels of care. Now, we need to expand equitable access to emergency CS cesarean section services by supporting more flexible financing models that reduce barriers to care. Yes, I was hoping I would hear someone try to give us an innovative way to for financing, but we need more innovative ideas about how to support this. Strengthen CMON capacity by investing in competency-based upskilling of medical officers, and then invest in maternal health workforce by addressing critical shortages of skilled providers across referral facilities to ensure timely, high-quality emergency care. So I'll conclude by saying referral only saves lives when the quality of care provided before and after are optimal. Thank you.
Nigerian brother, you have said it all. I want to ask this audience, how many of us have got critical ICU training? And I want Prof to look back. How many of us have got critical ICU training, even if you're a midwife or a doctor or a gynecologist? There lies our first problem, because we're not able to recognize on time. Then the second question is, how many of us really pay attention to the referral mechanisms that exist? I told you to look back. And the third, I'm talking now to the Kenyans. When we look at our insurance package, what have we been told? A patient who presents in emergency, what should happen? Kenyans, should it be charged or should it be free? It should be free. And how free is free? How many hours? Is it the 24 hours? Is it the 48 hours? Or it's until I get my AKI managed? Because to me, that's an acute emergency. True or false? As a result of my underlying hypertension disorder. So I'll ask another question. How many of us are participating actively in addressing the costing for the essential and emergency service health package currently underway? Prof, are you seeing? So ladies and gentlemen, in a nutshell, from that presentation, that's what I pick. How engaged are we with our system and with our financing to make a difference for our women? I'll stop there because I want you to think through. Yeah? It's not just about EMONOC training. I call it EMONOC, Emergency Obstetric and Newborn Care Training. There are a lot of tandem factors that we can make a difference if we learn to do what my Nigerian team has done. Look at the journey of the patient, but become the advocate. Thank you for giving me a recommendation that's not a recommendation, but a call to action. That's what advocacy does. Okay? So thank you for that. I really appreciate. Now, I think karaoke. Where is karaoke? Karaoke. He was here. Your turn. I hope you're keeping the questions, ladies and gentlemen. Accelerating adolescent and young parent engagement in antenatal care, a community-led approach to reduction of maternal health risks and the triple threat, which is HIV, GBV, and teenage pregnancy in Nairobi informal settlements. Good topic. Tell us who you are.
Good afternoon, everyone. Prof, I'm very sorry. I think when I was coming on yesterday, I didn't check the dress code. Yesterday, I just entered and I saw men in suit and was like, I'm in the right place. But I think I'm in the right place. Not that. Sorry for that. We are those people that we send things at the last minute. Sorry. So yes, my name is Josephat Karaoke, working with IREP, that is Ambassador for Youth and Reproductive Health Program, working with people living with HIV and those who are affected with HIV. So yeah, also this just to acknowledge that we work with other colleagues supporting Accelerate program with Population Service Kenya. And basically what we do with Accelerate is just amplifying the Accelerate to make sure that we end the triple threat and change behavior. So yes, like I said, this is what we do, accelerating adolescent and young parent engagement in antenatal care. A community-led approach to reduce maternal health risk and the triple threat of HIV, GBV, and teenage pregnancy in Nairobi informal settlement. So yeah, at the background, we can see adolescent and young parents living in an informal settlement face really multiple barriers accessing maternal health services, such as poverty, like period poverty, we're all aware of that. Gender-based violence, HIV vulnerability, where we see there's high risk of HIV infection due to biological, social, and structural factors. Stigma also and discrimination is one of the barriers. Limited youth-friendly services. At Accelerate, we make sure that we link our community to those facilities that offer services that are really directed for them. We have also inadequate access to family planning and preventive commodities. At Accelerate, we make sure that we supply these commodities to our community members and make sure that they are able to prevent themselves. And through Accelerate program, supported by Embassy of Denmark, Kenya, implemented by IREP Kenya, and just to say that Accelerate work in 13 counties in Kenya, and I'm sure most of you have heard about Accelerate and PS Kenya. So, like I said, youth targeted intervention were done, designated to address the triple threat, like I say, those, while improving maternal health outcomes. I might not be talking about PPH, but all these intervention and make sure that we as community might not end up to the level where we are suffering from, we're having PPH, because if we don't have behavior change with our communities, then some of these challenges comes in. Methodology was done. Most of the activities are interpersonal sessions where we met communities, have those discussions with them in terms of gender-based violence, maternal health, all those discussions. We did a community-led approach, was implemented between 2022 and up to now. That's where Accelerate started. And our target is adolescent girls, young women, young fathers, young parents. As like I said, without involving men, this cannot be achieved. Key intervention that we did was in ANC education sessions, where we make sure that young parents are really communicated very well, given those information, whereby as a father, as a young man, is your duty to make sure that either your girlfriend, your wife, or that woman that you're having with, you're taking them to NC's facilities. Peer-led sensitization, we made sure that we engage and sensitize their community to drive people with behavior change. Like I said earlier, without behavior change, some of these we might miss out. Like my friend from Kajiado and all those other places that they really believe in cultural diverse and all that. Talking about FGM, talking about diverse community might be really very difficult. Okay, technology. Yeah, so like I said, behavior change is a really conversation that Accelerate really focus on. Male engagement, like I said earlier, without men, we might done a lot. We might give all this information, we might target all the population that we want, but again, if not involving men, something might happen that is, we might leave some people behind, which are men. Referral and leakages to health-friendly facilities. We have those facilities that we know very well. When we refer our clients, they'll get the adequate services that they need. Family planning and HIV prevention, commodity distribution, that's family planning, condoms, lubes, and lubricants to the community that they need. Economic empowerment and referrals. Like Accelerate, we have those counties that we have economic empowerment, such as sewing machine, where young girls and boys are able to be educated on that. SGB prevention and initiative, raising awareness among support, providing support and promoting safe and productive communities. At Accelerate, we are linked with GVRC, that is gender-based violence, where we link our clients to where they get these facilities, where they get these services, For those that may want services if they have been violated, they need refuge, they want a shelter, GVRC provide that. And as we say, community champion, with our community champion, they trace referral and support follow-up to enhance service uptake and improve maternal health outcomes. The results for the 5 years we implemented, we were able to reach at least more than 500 adolescent and young parents, reached and engaged. with maternal health education, ANC referrals, family planning services, and HIV prevention. We also improved on ANC in attendance and health seeking behaviors. Like I said, without having this conversation of behavior change, the health seeking behavior might not be achieved. Male involvement, that's what we really look at so much. We increase supportive ONC visits, share parenting responsibility, and uptake of maternal health services. Community dialogues like IPC session, interpersonal session, we will conduct them monthly to reduce myth, harmful gender norms, intimate partner violence, that is IPV, and barriers to accessing reproductive health services. Economic empowerment leakages further strengthen retention and care and service utilization. Conclusion. We've integrated mental health, as we all aware that as much as we do all these services, we uptake for these services, mental health remains one of the challenges that community really face, that many are not supported in terms of even funding and all that. Mental health has become a challenge, and at Accelerate, we made sure that we have this session where we talk about mental health, HIV prevention, and all those three portraits. Male engagement, like I said earlier, and economic empowerment. Community-led intervention of scalable solution for reducing preventable maternal death and advance equitable maternal health care in underserved setting. Thank you so much.
I like that. He has made me very happy. He's repeated the word male engagement 5 times. So the men in the house, are we here? Without your help, we can't go far. So thank you for really emphasizing that. And emphasizing that we really need to take care of our adolescents and our youth as single and as parents. I want to do a shout out. Is Masoud here? Et al., who were to present at the first point? Going once, going twice, going thrice, not here. And Simbanda, not here. Is there any group I've left out who was to present that has not presented? AHB, next time it'll be your turn. I'm aware you're a private practitioner that's sitting pretty. We need to hear the private practitioner's voice. Question time. Don't go far, you'll run around. Me, I'm old. Right. Questions? Questions? Great. Katia Daktari Wameru. Another person with a question? Okay, go ahead. It wasn't working. Give us another mic that works. Take another mic.
I'm audible?
Yeah,
Yeah,
perfect.
thank you. Lovely. Thank you for all the presenters. To my brother from the West, thank you for referencing me. And I hope you pay back in kind.
For plagiarism.
Yes, you talked about a guy in Monaco saying that he's happy to be here. Yeah. So to borrow from you, I think you've served my favorite dish, especially by speaking, especially on NTS. And I think the comment that I would make is you might want to consider the role of non-technical skills again. Because like from our experience, what we've done is that we've sort of have a countdown that by the time a mother has elevated blood pressure, within 30 minutes, then the clock is ticking, that preeclampsia has been, I mean, if it's severe, it's been diagnosed, and the magnesium sulfate has been administered. And what I've seen in terms of helping this, it gives people that mindset. Because oftentimes, even when there are delays, sometimes it's not that the magnesium sulfate is not there. It is because of our own internal processes. Yeah. From experience, what we used to see is, you have to get the file for the patient, the labs have to be drawn, the doctor has to come and review this patient. And so the question that I would ask, because I was quite surprised by the figure, I think it was 46.8 in referral facilities did not receive the loading dose. Who makes the decision on who needs this magnesium sulfate? Because I think From our experience previously, we used to say the doctor is called to come and review this patient. But sometimes the doctor is busy. So what we do now is that the midwife will consult the doctor, and with the clinical history and the labs, then if we've made a decision that this is preeclampsia with severe features, then magnesium sulfate is administered, so that we do not have the story of what it is Jesus asking, if an ox falls into a well on the Sabbath, are you not going to pick it because it is Sabbath? So if a mother comes with preeclampsia with severe features, I don't think you really need the doctor to come physically. I mean, if you've been given the information, to come and now write the prescription of the magnesium sulfate. But otherwise, thank you for serving my favorite dish.
Well done. Well done. Another question here. There's another hand up there. Go ahead. There. The back.
Good afternoon, everyone.
Good afternoon.
Mine is just to say first, thank you for all the presentations, but I have two burning questions. One goes to the lady from West Pokot. My question to you is, how do you handle male chauvinism and the age gap difference among the society as you conduct your day-to-day service delivery? I'd really like to know, keeping in mind that the issue of culture, you have said, is very much deep-rooted wherever that you conduct your service delivery. Number two, we are here talking about ending PPH. But what if it happens? Have we looked at the traumatic aspect of what remains amongst these mothers? What happens to the spouses who come in during the birth companion delivery? Are we looking at what happens to the male who come and experience what happens to their wives or their female counterparts during the service, during the process of delivery? We are much embarked on the women, but remember also male are human beings like us, and they have that perspective and they have emotions. What are we doing also to the male? Do we have debriefing after that? And the aftermath of PPH, after it happens, what next? We have left the aspect of the children. I'm a very passionate neonatal nurse. After that, have we looked into what happens to that neonate? There are some mothers who even do not want to touch their children. So I'm thinking we should cut across it. As much as we want to end PPH and get the zero curve, we have a long way to go before we can reach there. And remember, it is a multidisciplinary issue. So we have to combine each and every aspect of everything before we can completely end PPH. It cannot just go as a one tap. It needs steps. Thank you.
Well done. Yep.
Yes. Thank you so much for all the presentations. They are very educative. My name is Edith. I'm a midwife in the house. I thank our brother from the West. You touched a very passionate issue on preeclampsia. But I'm here to ask, when you say that a midwife should call a doctor or I have to wait for a doctor to come, what is the scope of practice, Prof?
Yeah.
If I'm told I cannot cannulate because I am a nurse, because the doctor was not there, there is a private patient I cannot touch before the doctor gives an okay. Yet I know the loading dose of magnesium sulfate that I should load before another fit occurs. Maybe we need to be told in this sitting. Number two, my girl from Kajiado County, that's where I live, the nomadic communities. I have gone through FGM, and I've been told I've got to get married maybe at age 13 to 15 is when most of them go through the FGM. What have you put in place to ensure that now the cultural practice does not cause me to have PPH? Because you come and get every flesh from my private part. When healing occurs, there's a lot of scarring. So by the time I'm pushing my baby, that vagina is destructured. And so bleeding is inevitable. So maybe I don't know what you're putting in place to ensure that that is addressed at the community level for the community people to accept it, not us telling them do not do. Thank you.
Well done. Well done. Another question? Here in the middle. We'll take 3 and then give an opportunity for answers.
Good afternoon, everyone.
Good afternoon.
I'd like to appreciate all the presentations that have happened. Something that I'm keen on is what has been talked about, teenage pregnancies. I know when you talk about maternal health, it's really quite important for us to talk about teenage pregnancies. And coming from Endebess sub-county, we've been having a problem on how to go about this. And I think something that I'd like to put across and maybe pose this question to you: what are the policies around family planning for some of these young mothers? Because we tend to find a lot of them who've already had one child, but then when it comes to the issue of advocating for family planning, there's the point where the policy says somebody who's below 18 cannot give consent to any sexual intercourse, so they are not allowed to have family planning. Perhaps I'd just like to hear the conversations around that. Thank you.
Excellent comments, excellent questions. So, the speakers who were on stage, please, I'm giving an, oh, there's another question, Banning. Let him ask us. Great. Thank you, Prof.
Thank you, Julius Ogengo here, University of Nairobi. Dr. Oladipo. First of all, excellent. You touched me. I feel happy when I shortlisted the abstract. It's a tick.
Great.
Now, Dr. Oladipo, 2 things. You choose how to respond, and you could also not respond. Hypertension diagnosed in pregnancy, which is not preeclampsia.
Chronic.
How did you link it in your observations to preeclampsia? The follow-up to that is, how did you factor in the concept of recurrence of preeclampsia in that, if you manage that? Now, the other one is to the ambassador for youth.
There were 2.
The karaoke. I love male factor. But I wanted to, when I was listening, so that I don't say the wrong thing, you know. Older children are highly important and play a multifaceted role during a mother's pregnancy. I am pregnant, they have other children. The male you talked about, was it just the spouse or also included the children? The male child. Just a comment, and that would be important. The 3rd or 4th, related also to karaoke, lovely child motherhood. When we were a little younger, did a little survey to debunk the issue of age at menarche. And the finding was this: over 10% of girls who achieve menarche now before 10.
Yes.
Before age 10. 10% achieve menarche before age 10. So it is possible that a girl achieved menarche at age 8, she conceived at age 8.5. So by 12, she has a second child. Children who are children. We tend to put a lot of emphasis now on youth and adolescence, but there is the child mother, mother-child or child-mother, whichever, and
Child?
the baby, who is not adolescent, the pre-adolescent mother. We all tend to think about adolescent and youth pregnancy. Now the issue of mtoto, mama mtoto, that one. If you comment on that also, it would help. I thought it would spring out. I thank you.
Thank you. Let me start with my Oladipo. You have most questions.
Okay. Thank you so much, everyone. I think the questions point to the fact that we were paying attention. Okay, so I'll just tie Doc's question with that of matron. Okay, so generally speaking, from the guideline, there's no restriction because the matron or the nurse is qualified to administer the medication. So usually, from even observations within the facility, the delay is not in waiting for the doctor. What we saw was that the problem was some form of limited clinical decision making. For from the phase 1, many of them had not gotten trainings in over 10 years. Some of them had forgotten a protocol as simple as that. And for some of them, confidence comes with knowledge. So for some of them, just the fact that they didn't know how and when to prescribe, they just stayed away from it. So which is why some of our recommendations are investments in those trainings, mentorships in facility, and just issues with making sure that facilities have enough skill-based attendants that are trained. Thank you. So I think I would answer the other question about hypertension diagnosed in pregnancy, which is not PE. How do we link it? So for the purpose of this study, we ensured that to even enroll a woman in the first place, just to keep it simple, we made sure that the diagnosis had to be made. So if a woman presents at the facility and blood pressure above 140/90, significant proteinuria, she's enrolled. If you don't meet this criteria, no enrollment. And if the woman's first presentation is eclampsia, that's convulsion, and then with the diagnosis of with significant proteinuria, elevated blood pressure, we enroll, just to ensure that our inclusion criteria was just very simple and direct, to ensure that we are not including many other women that shouldn't be part of the study. Then for this particular study, we didn't really factor in the occurrence of preeclampsia, because for our focus, we're just trying to see, so even if a woman has the predisposition to have preeclampsia again, our point of focus for this was referral completion, and then the quality of care at the PHC, quality of care at the referral facility, and the associated factors. So I'm sure these are some other things that further studies or even larger studies will consider. Thank you.
Okay, karaoke. Men. Motherhood in childhood.
Oh, okay, sir. Thank you for that question. So what we looked at in terms of male, the question was either is male child, either spouse or the child for the mother, right? So it was overall. The reason why we did that is because, as some instance, we got those single parents who they have boy child, and we cannot leave them out because most of them, they had maybe little or no information on SRHR or GBV. So at some point, we met the son who was belonging to the mother, and also the spouse. The spouse was really important because without the spouse, some of the issue we were seeing is IPVs, in terms of when a mother goes to NC visit, when he comes back, there's a lot of issue at home. So we saw a level where we can include all of them to go to those facilities. The child motherhood, those were the very aspect for us, because without integrating male in terms of what a woman needs, that become a problem. So yeah, it was an overall for us. Thank you.
Okay, is that a question? Before the question, there was the issue of nutrition. The family planning, yes, the nutrition, but you're the nutrition group. I want to bring up something. When we talk about PPH, yes, in this congregation, we've talked extensively about anemia, haven't we? But I want to break it even further down. Why are you so worried about anemia in the adolescent mother? Maybe you can answer me before I answer. Pregnancy brings on anemia in two ways. One, the physiological anemia of pregnancy, which is the dilutional effect as you carry your baby. Yes, in preparing for that childbirth. And then we have the pathological anemia. But how many of us have asked those young mothers, or even people who are a little bit older, what was your menstrual cycle like before you even got pregnant? Why am I asking this? Today we have an entity called heavy menstrual bleeding. with different causes, polyps, fibroids, even cycles because of hormonal imbalance, if I can put it simply, or what the doctors will talk, and ovulatory cycles. There are those who have got congenital diseases that predispose you to anemia, sickle cell, G6PD, the list goes on. But then again, you have what has been an influence of your environment and climate, which Professor has been alluding to quietly. And then you have the commonest, which speaks to nutrition, malnourishment. And I want to look at malnourishment twofold. The lack, which is very common because of poverty and low socioeconomic status. You'll be lucky to get 3 meals a day, let alone 2 meals a day or 1 meal a day. And there is a malnourishment on this other side of plenty, the KFCers, who are eating junk food, and the mandazis we have eaten. Hello? You're all malnourished from junk. So you look nice and robustly healthy, if not obese, but you're actually malnutrited. So I don't want you to lose that. And then you have the malnourishment, and this is really pathological, where we have old practices of using fuels such as charcoal and firewood. So your hemoglobin deceptively looks very, very high because you're compensating, because you have met hemoglobin. It's not carrying oxygen, it's carrying carbon monoxide. We don't think about it. But is it going on in our villages? Hello? And then add on pregnancy, where the demand now is not only for the mother to fuel for the baby, but for the baby to get enough for nourishing itself. So you end up with a low birth weight baby, and we now have what I will give you as homework, fetal programming for non-communicable diseases. That carries on for the rest of that baby. The other thing I want to talk about is with PPH, we have endogenous oxytocin that's released by a mother when she starts breastfeeding. None of us seem to talk about it, that's a natural mechanism to check for PPH. But how many mothers, and even go to our data, have the baby put to the breast within the golden hour? I'm speaking nutrition. Within the golden hour. Oh, she's in a lot of pain. Or she's come from a cesarean. Let her relax there, the baby there. Or the baby is taken to NICU. My neonatologist, I know you can attest to me. And that baby suffers from dehydration, AKI, and will collapse because that baby did not get nourishment. Or will go into hypoglycemia and the complications thereof. Now let's look again at the same mother. Excessive amount of bleeding, you have what we call Sheehan syndrome, or necrosis of that gland called the pituitary. She will not be able to breastfeed even if she wants to, no matter how much you put her to that breast. So my challenge to us, can we look critically at nutrition, starting from our clinical visit, even before pregnancy, into prenatal care, and ask those menstrual cycle questions. And then post-delivery, what is the nourishment like? Because early childhood disorders or other issues or dysfunction start there, the golden hour. I can talk a whole lecture on just oxytocin. In another word, it's called a love hormone. Prof, that's a love hormone. It's for binding and bonding the baby to the mother. I think some mothers, even as young adolescents, do not even seem to have good receptors for that because they've got so much anxiety going through them. Is that baby wanted? Do I want it? I need to go back to school. In the family setting, do we have the economics to bring up this child? Those are things, the mental health. Where is Karaoke? He spoke about it. the mental health issues surrounding pregnancy, childbirth, post-pregnancy. We have to think about it. But again, I want to look at Prof and ask, there's menarche when we start our menses. It's happening less than 9 years of age. Then there is koitake. When do you start your sexual debut? And I'll call it also the time to suit my good girlfriend who's come in, Rose. The vaccinake. Vaccinake is HPV vaccination, where I strongly believe should be the beginning of a conversation about comprehensive sexual education. Why? Cancer of the cervix, is it common in our setting? Is it being trapped too late? Can you put a stopgap as you do the prophylactic vaccination of the young girl who apparently is brought oftenly accompanied by a guardian or a parent? So you'll have caught two people at one sitting. The mother for screening and the conversation that the parent may not even be able to give. But in the presence of a doctor, it may happen easier and effectively. And then we have the boy child. Again, I'm a firm believer on herd immunization. But in Africa, most of our continents are saying, at least give the girls to begin with. But where you are already robustly in your programs, we need to also have the boy child, because HPV also goes to the boys and will still be propagated by the boys. So you can see the intersectionality that we must begin to have. And I like the way we had the triple threat talk in this lecture. We also need to talk about the triple burden, which is HIV, syphilis, hepatitis, real diseases. And I've always said, wherever you look at a teenage pregnant woman, think the story behind the pregnancy. Don't just look at her as pregnant. There's something going on. Lack of health literacy, gender-based violence, alcohol and drug abuse, rape. Hello? 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 Are you with me? So when you look at the teenager, and I think these talks have really focused very heavily, or even now, the persons with disability, who unfortunately, majority of them end up being defiled within their own homesteads, or by persons known to them who they have put their life in their hands and they've changed it around. Are they able to talk? And even if they can they say it? Kajiado, where are you? You spoke to us. Yes. Do you agree with me or you don't agree with me? So the vulnerabilities, when people are in wars and conflict, what is happening to women and children, and particularly the adolescent and youth? So you are the community that needs to speak up. You are the community who is going to stop PPH from a proactive approach. Go upstream. Go upstream. But we recognize NCDs and communicable diseases are two elephants we can't run away from. I hope that was clearly articulated in this session of health system strengthening that we've gone through. But the fact that you are there, you know what happens, you know the culture of the communities you're coming from, and we've even been told if you cannot give them the literacy because they're illiterate, let's use song and dance. Let's use song and dance. There's nobody here who doesn't have a traditional song and dance to get the messages across. Bottom line, we must communicate. We must communicate. I'll hand over to Prof because now I think I can continue going. Thank you very much, and thank you for my presenters, and thank you for being a wonderful audience.
Can you clap louder? Dr. Wanti, there were two people who wanted to say something. Can they come quickly before we are hungry now? If they are far, we go and eat. there's a team out there.
Maimuna, Dr. Maimuna, please come forward. Then Elizabeth Omondi, is she here? Ovamra. And Ramla Jamal.
You are giving them how long?
5 minutes max.
2. Okay. May I will give them 2, but okay.
Be nice.
Presentation.
5 minutes.
Hi, how are you? Prof, be nice. You taught us in med school. Good to meet you all, and I'm very happy to be here. My name is Dr. Maimuna. I am founder and CEO of Taria Health. Taria Health is a wellness and health navigation company. Now, you know you're doctors, so usually when I talk to non-doctors, they want to hear about everything that means. But when we talk to doctors and you say wellness, you agree it can sound very amorphous, yeah? So I'm going to wrap it up for you in a few minutes so that you understand. So as doctors, medicine has made us very good at increasing lifespan. You agree? We have new interventions, new developments. The problem, or where we are failing, is what we call health span. What is the difference between these two? Lifespan is how long you live. Health span is how long you live without having to take any medication. The average person will spend the last decade or more with at least one tablet that they're taking. Now it's multiple. So what we are trying to say is we need to look into health span medicine. And how do we do that? It does not mean new tests or new interventions. It's actually using the old tests better. So there are 4 metrics that help us improve health span. The first one is what we call metabolic flexibility. What is that? Your HbA1c. Right now, HbA1c is becoming one of the biggest predictors of longevity and aging. Your resting glucose. I'm sure you've seen Kipchoge and the likes having a continuous glucose monitor because you want to know what your baseline sugars look like month on month. Your waist-height ratio, not even waist-hip ratio, but we're also doing the waist-height ratio. So these are some of the things that if you keep track and make sure you're reversing them to the right number, you improve the number of years you don't have to take a tablet. The second aspect, other than metabolic flexibility, is inflammation, reducing inflammation. Now we have a word we call inflamma-aging, yeah? So Doc mentioned KFC, mandazis, the pollution in these streets, yeah? So there are certain things in your control, there are certain things that are not in your control, but the point is this slow or inflamma-aging is depleting the level of epithelium you have, endothelium you have, and this is becoming a predictor on longevity and health span. The third thing that will improve your health span is muscle. Muscle is now an all-risk predictor for mortality. So, do you know your muscle mass? Do you know what percentage of your body is muscle and what percentage is fat? And how are you working to get this? Muscle now is an endocrine organ. It's no longer considered a tissue, a movement tissue. Today here, we are doing for you for free your visceral fat percentage, and if you put it in a calculator online, you'll be able to know there are people who are 50% fat, there are people who are 20% fat. The question is, you want to increase the muscle mass because that is what is going to reverse age you. And the last aspect of health span is nervous system regulation. Chronic stress is a predictor of how long and how well you will live. And now things like psychological safety, emotional safety, financial safety are not soft wellness talks. These things actually affect how long you live. And if I'm to hit home a bit, I'd like to talk about connections in terms of autonomic regulation. There are connections that will add years to your life, and there are connections that will reduce the number of years you live. Unfortunately, there is no doctor who will tell you that. It's for you to know those connections, that make you tense up. You don't want to pick that phone call. You are triggering your cortisol levels, which at perpetual states, or if you're exposed to this, and it could be a relationship with a partner, a parent, an employer, even your bank, even a startup. I'm in a startup, and I could tell you that there are moments I feel it's a toxic relationship. But I tell myself we have to impact lives. You need to know which connections to cut off, which connections to draw boundaries, and which connections to change your perception around them, because you need to reduce your baseline cortisol. So, what is wellness? Now, I've told you all that. So if I was to give wellness a scientific perspective, I'd tell you is to maintain physiological resilience so that we can reverse pathology. Have I made sense? Okay. So for you today, we are here as Taria Health, the wellness partner for PPH Foundation. Why are we here? We need you to be healthy so that you can treat the mothers to be healthy. Please start with your basics. They will give you your BMI, they'll give you your body fat, they will give you a few of those. You are doctors. Dr. Ogengo told me, the report is off, Prof. He told me, no, the metrics you gave me are not right. Yes. The point is, that is what we found. How you reverse that, how you maintain that, and how you sustain that year on year is what will make the difference between if you're walking at your end of life or if you're living assisted. Thank you.
Hello, everyone. My name is Ramla Jamak. I'm the founder of Mobile Orca. But firstly, I would like to thank the organization and everyone here as well for having us today here as well. Having great conversation, but also learning a lot, what is happening on the ground and hearing different perspectives from people in different roles. It has been really insightful. So what is Mobile Orca? So Mobile Orca is a women's health tech company, and we actually focus on improving maternal health across sub-Saharan African region. And what we've built is a precision maternal platform for healthcare workers, for OBGYN, nurses, midwives, community health workers. And the idea behind it is that through our mobile app or the desktop, we prefer route, what you then put is information of the patients, we fully analyze it, and based upon that, we then predict several pregnancies, disorders, even from the first visit. So what we want to achieve with that is actually that we want to shift maternal health care on the sub-Saharan African region from a curative to a preventative and a more proactive approach, which will actually enable earlier interventions. But on top of that also, it will help healthcare workers to effectively allocate your resources. And ultimately, it has better outcome for the mother and the baby. So we're here at the PPH conference today, very excitedly so, to know that we can only achieve that in partnerships while working with others. So if our vision and what we're trying to achieve also aligns with you, I would love to have a conversation to hear your insight and to see what we can also do together. So thank you very much, and I look forward to connecting with a lot of you. It's quite short also for the sake of time, because I know we're all very hungry. But thank you, guys.
Yeah. Good afternoon, everyone. Yeah, thank you so much. My name is Elizabeth Omondi. I work for Amref Health Africa as a technical officer. I'm based in Kilifi. But today I'm very happy to be part of this conversation because as Amref Health Africa, we are committed to support in ending preventable deaths. And Amref Health Africa, we have a presence in almost all the 47 counties. And for this conference, we were able to be represented by 2 of our counties, that is Narok and Kilifi. They were able to present what we do together, the collaborations that we've done together. And as AMREF, we made a bet that we are going to contribute to reduction of maternal mortalities in Kenya. And we are doing that through working with counties, supporting them to do various interventions that are high impact. And also, we've also realized that for counties to implement some of these things, they need to learn from other counties. And we are very deliberate in terms of ensuring counties are able to learn from other counties. And I know from this conference, we've picked key things that we need to continue to collaborate, to work together. We need to continue to engage communities in terms of improving our health outcomes. And also we need to ensure that we use the non-technical skills to ensure that we reverse some of these trends. Because when you look at the trainings that have been done, we've done several trainings to several healthcare workers, and we continue to do the trainings, and we are not seeing change. So it's important to ensure that also the non-technical trainings are also employed, and also do research so that we're able to document and use that to create curriculums that are going to support the healthcare workers. But because when you look at the maternity units and the newborn units, most of them don't go through the other trainings that the other healthcare workers in the rural facilities are able to go through. So most of the time they have burnouts, and they're able to translate that to the care that they produce. So thank you so much for giving us an opportunity as AMREF and also counties to participate in this conference. And we are committing to take the learnings to support the healthcare workers that were not able to be in this conference. Thank you so much.
From preventive medicine, health promotion, wellness, thank you, Dr. Maimuna, to curative care, to rehabilitative care, to palliation. That's the whole sequence of our medical lives. The question is, what have you left here with? We've featured safe motherhood across that whole spectrum, starting from the very young adolescent who gets pregnant, to maybe even the perimenopausal. I didn't hear anything there, but I want to believe a lot of the chronic, non-communicable diseases are slightly the older group. And knowing that a lot of us as young women nowadays are deferring pregnancy until we're over 35. When you ask them, they say career first. Hello? Is that something I'm hearing alone? A lot of them are saying career first, husband lacking, artificial insemination, yet another possibility. Ogengo, that's where women are. But the bottom line, no matter how we are, we've got to remain healthy. And SDG 3 talks about what? Health and well-being. So the wellness is not ectopic, but we have been ectopic in addressing it. So thank you for reminding us. We have a wene, every woman, every newborn, everywhere, and I even add every time should count. We've talked about the spectrum in the continuum: antenatal, skilled birth, postpartum, emergency, and even social determinants. My nutrition group spoke extensively about group antenatal and peer support, was the other paper. But how many of us talk about empowering women even financially? Food for thought. How many of us are aware right now we're actually revising Ewene? I'm lucky I've been on the global stage with it, to actually feature children up to 2 years of age. So we're extending the nursing of that newborn to 2 years. Reason being, up to 2 years, that's when most of them die off, and you talk about the child mortality by 5 years. And to note, that's also when we are kicking in early childhood development, the milestones. So when a mother gives birth and the baby is malnourished and the baby's cognitive development doesn't happen, the likelihood that that baby's intellectual development will be compromised, it happens very early. And we've got to put a stopgap. The other thing in Ewene is the 3 pillars that we address Ewene with on the global stage. And the 3 pillars are namely this: advocacy, health system strengthening, and data. Before I left the stage, I did not talk about innovations. Where are my hackathoners here? Hackathoners. I know you're waiting for the results. We have them. But I want to give you homework. Yesterday, a lot of you gave us the patient-centered innovation. I want you to move upstream to the clinician-centered innovation. Because all the AIs we are doing are looking at clinical, digital decision making. Are you with me? Hello? I may be talking only to you. There are others here who will be, what's this? But that's what we need to do. Look both at the patient and also look at the clinician. What can I aid the clinician who has PE diagnosed to have escalation of care that is appropriate, and then appropriate and timely intervention? I have ideas, so if you want to talk with me, you can talk with me later. But ladies and gentlemen, we've had a fantastic post-health break, I think. Have you enjoyed it? So that you're all well, can we all stand up? All of us. I want to do something that's different, which you don't get to hear oftenly. Now look for space where you are, please. Look for space, because you're going to jump. I want to take you somewhere in Africa and in Kenya. Hey, my friend, Rwanda, Victor, computer down. Put it on the chair. Have you got space? We talked about the role of culture and art, didn't we? Huh? So we'll do the drum beats from an African nation. Rose knows it. That's all you'll say, okay? Arab ki baigano ye chungeni nguruet. Chungeni nguruet oh ya soro bumbusiek. Soro bumbusiek oh ya chebo amtakara. Iya ho ya he. Iya ho ya he. Go for lunch. See ya.